Okay. Hello, 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 everyone. Welcome to another edition. Welcome to What's Up, Doc. It is our regular series where we interview doctors from around the world. This time we are focusing on Italy with Dr. Lorenzo Patrone. He's an interventional radiologist from Florence, Italy, or in Florence, Italy now. He was in London before, but you know what? Lorenzo is all over the world. And in fact, for many of the new patients that are just tuning in, Dr. Lorenzo Patrone was our very first global PAD doctor of the year, which we probably put a little target on your back, but it was well deserved. Still, if I could make you global vascular doctor of the year every year, you know I would. I think you are our overall patient champion. And I think every year I have to come up with something new to call you because you just deserve so many accolades for the holistic approach that you take with every single patient and making every patient feel heard and going the extra mile to ensure they have every single opportunity to have their limbs saved. So, on behalf of everyone in our network of 12,000 patients globally, we thank you so much for all you do.
Nothing
Now that you have
special,
nothing to
just
say.
just being passionate about. No, yeah, I mean, like just being passionate about what I do, and I understand that many people are scared when they get their appointments. I know that many people have problems in short appointments with their doctors. So essentially, I think it's a big part of my pleasure of being online with people is trying to fill this gap between they say like the normal consultation and their doubts. And actually, sometimes I understand it's also easier because if you are on line, then it's easier. It's a bit more less personal, let's say, and that makes it easier sometimes to interact with doctors about something that possibly you just discovered. So yeah, very happy to have been on your side for so many years. We started in 2018 or 19, and I think that since then you are an angel. You support so many different people. I just try to help whenever I can, and actually has been a good journey also for me to understand patients better in a more like informal setting, let's say.
Yeah, there's a lot that you don't, as a doctor, see or hear from patients in that 15-minute consult that you are designated inside or even allowed inside that hospital room, right?
Absolutely. Essentially, sometimes, people have loads of questions, they understand little. And I think that's the project that you started with empowering patients in understanding better what's going on with their pathology, with their disease. It's a very difficult one, but very important because essentially people also can understand possibly better before going to a doctor what's going on with their legs, having a better understanding of what the doctor says during the appointment, and having even more information after the appointment in order to understand if what is suggested could really be the best option for them, which is sometimes is not the case. So essentially, it's good to have different options and different operators talking to you, and the support that you give to patients is amazing, and I love it a lot.
Thank you. I'm just curious. We see in our group every single day the amount of debilitating pain that peripheral artery disease can cause. And I've had so many doctors tell me that they've never really, until they got into the group, the ones that are in there, that they didn't really comprehend the extent to which these patients were truly suffering. Is that something that you experienced, or is that something that you kind of just knew all along?
No, I mean it's definitely, when a patient comes to you and tries to share with you his or her story, it for us it looks like sometimes the same story all over again. Like, okay, I can't walk. Okay, I have ulcers. Okay, and it's always the same thing. You in a way you think that your disease is special, but it's not, because we deal with that every day, and for us it's always the same. What's really the difference, and that is what sometimes is difficult to appreciate during a quick consultation, is the patient story behind it. What the disease means for them, what activities the disease can affect. And actually, like, the more you read into like the stories that people write in a very, let's say, spontaneous way, the more you understand how this can affect. And sometimes, as I said, like we as doctors, we categorize, of course, the peripheral artery disease in two big groups, the claudicants and the critical limb ischemia. And for the critical limb ischemia, it's bloody obvious. I mean, people can't sleep because of the pain. People have ulcers on their feet, so it's very easy to appreciate the amount of disease that the people, and also all the burdens and all the difficulties that someone with critical limb ischemia faces. On the other side, because I mean, there's been a lot of people treating, I would say, in the past, people with claudication right and left, and then it has been demonstrated not to be a great long-term solution. Then we tend to classify the claudicants as claudicants. Oh, he's a claudicant. Oh, she's a claudicant. And it doesn't need treatment. And actually, like, of course, there are long-distance claudicants. That could be even 1 kilometer. There are short-distance claudications, like 50 meters. Of course, these patients are very different. I mean, it depends, of course, on how much they move, how much they go around. If someone just goes around his or her flat, then you don't have to run 1 kilometer. But if someone is young and has an active life, has a job, as a courier, for example, I treated once, these people, even 100-meter claudication can be, a very disabling disease for them. And actually, I think we are prone to underestimate the impact that PAD has on them. And that's, I think, and by reading the stories, as I said, online, and by listening to people a bit more, also improving my communication and listening skills every day, I think I got it more what it could be for a patient to be affected by peripheral artery disease.
I think we're all learning and growing every single day, when it comes to that. My listening skills are definitely improving, not perfect, but every single day, just little by little. So I wanted to, before we get to some of the other questions, we have a live studio audience here. You recently moved to Florence, Italy. Talk about your practice there and what you're focusing on and what patients can expect from you.
Yeah, I mean, I'm Italian myself, so I was born in Genoa, which is northwest of Italy on the coast, and I moved to the UK in 2016 when I was 31. Now I come back to Italy when I'm 40, so 9 years later. And actually, what I liked from the UK is, like, there's a very good team approach to the pathology, which, like, of course, enriches a lot your own skills, but especially your own knowledge of the pathologies. At the same time, what I didn't like, really, I couldn't build something which was meaningful to me, essentially, because everyone, I don't know if someone is from the UK, but you have these consultants work independently in a way, so everyone is in charge of his patient or patients. And I think that it's a bit of difficulty sometimes if you want to push the boundary, if you think about something different, because all the other, you don't have someone who really dictates a clinical way. So it's like, okay, let's do this way and off. No, because everyone has his own voice, everyone can decide for his patient or her patient, and everyone is the same. So this is something that I really struggle with. Because, of course, for example, you have someone and you listen to the story, you say, God, this guy needs some treatment, because, and they go, no, that's too dangerous, or too. And actually, I mean, like, if you do some stuff every day, if you are a painter, if you are, like, I mean, let's say they are a circus entertainer, you jump on the rope, and if I do, or if you do, then of course we're going to jump out of the rope and we're going to break our head and we say, oh, that's dangerous. But if if you every day do the rope and you have some skills, then at the end of the day, you won't jump out from the rope, or if you fall, then you will minimal damage, or most of the times. So that's more or less.
I'm good.
Whoops,
yeah, that's more or less what I yeah, it's Joyce. But it's more or less what I felt like. I wanted to move back to Italy, where there's more clinical leadership. Of course, it depends on who's the clinical leader, but I found myself very happy in this place where they actually value my input. That I'm the point of reference for all the PAD lower limbs patients, and actually there are lots of people who are willing to learn, and it's this kind of a very good feeling with, like, in a completely different culture and environment, and I really love it. So Also, in between the other things, I'm going to start also my training in open vascular surgery
Wow, that's amazing.
as interventional radiologist. I'm what I can offer. Yeah. Yeah. So in November, alongside my job, I will start also the open surgical training, which is something that I always wanted to do because I feel that, of course you can fix most of the stuff endo. But today, for example, I had a case which was like complete madness, with a reconstitution, is a CLI patient with reconstitution at the level of the tibial vessels. And I said, they are super small. And I said, whatever I do, I will destroy this landing zone. I will damage these vessels. So I said, okay, despite I'm very pro endo, I said, okay, I will stop. I discussed with my colleagues, I'm going to perform a bypass there. Because 1/50, 60 really deserves a bypass. And I didn't want to end up being the guy who only can move a guide wires and catheters. I want to be the guy who can take care of lower limbs, in different ways. So at some stage I say, okay, I will offer you the best option, what I think is the best option for you. Because to be honest with you, the case of today, the best option was surgery. She had a vein. So the best option for her was bypass. And, of course, I work in a team, so I was able to call colleagues and discuss the case, and someone else will give her this option. But in the future, in the next 5 years, I want to be the guy who can give all the options to my patients. So yeah, that's also the meaning of coming back to Italy.
Yeah, it just speaks volumes for your character and your commitment, to patients and ensuring that they have the best quality treatment to have a better quality of life. So, if anyone's just joining brand new, now you know why. Lorenzo is our senior physician advisor for the Global PAD Association. He's just amazing. So, Carmela, I want to jump into some of the patient questions. Carmela, who is right here. Carmela, go ahead and unmute, and you can ask Dr. Lorenzo Patrone your question.
Hi. My question has to do with what possibilities beside the slow process of growing collaterals would there be if I have a totally blocked left iliac artery, a stented right iliac artery, and now a totally blocked fem-to-fem bypass with some blockages beginning to start in the legs?
Okay, and sorry to ask you, which are your actual symptoms now?
Some discomfort at night when I'm sleeping, aching legs, and of course, when I try to walk, I get pain. Mostly it starts in the lower back, the glutes, and the hips. And it's been like that for a few years now. I was told that the only option when things got bad enough would be to have a procedure that almost sounded like what Douglas had, where there would be a graft that would go from up in the shoulder area.
The axillary bifemoral bypass. Where are you located, Carmela? Have we talked before?
Yes, I'm near Harrisburg, Pennsylvania. So I have a doctor in Camp Hill.
Okay, that's Dr. Raj Dave.
Yes.
Okay, so listening to what you say, that's important that you mentioned the buttock pain, for example. So the buttock pain, you think that every single, let's say, segment of our arterial tree can give you different symptoms. Whenever you have a blockage in the iliac artery, especially the common iliac artery, which is exactly the branch which comes out from the aorta, then also, this branch, the common iliac artery, divides in two other branches. One is the internal iliac artery, and the other one is the external iliac artery. The external is the one then going to the femoral and down to the, let's say, with different branches to your foot. The internal is the one which is going to your pelvis and to your buttock. So there's an anterior branch for your pelvis and a posterior branch for your buttock. When people come to me, and actually not only to me, to everyone, and have this kind of pain in the buttock, which starts, that means that, straight away, without even doing a CT, I'm not a magician, but I can tell you that you have some common iliac disease. Because whatever is below the iliac bifurcation, like internal with external, then we'll just take your leg. But whatever gets to the buttock, that means that it's involving the common iliac artery. So as you said, you have a blocked common iliac artery, and you said that on the other side you have a stented one. Just my
Yes.
question is the stented one patent or not?
It is open.
It is open. So is your pain in the buttock on which side? Only on the part which is stented, or on which part?
Both.
Both. So that's curious, because I mean it looks like something that could also be not related to the PAD. And did you have a CT scan at all?
Yes, I recently had a heart scan.
CT scan of the lower limbs.
Yes, they did that.
Okay, because that's important to understand, because if you have a stent which is patent on one side, on the other side you have occlusion, I expect you to have different symptoms on, between two sides. Of course, your pain in the night, is it on both legs?
Yes, and I think that's because that femoral bypass is now blocked.
The fem.
Yes.
And the fem. Oh, I understand. Okay.
That was
Okay.
done back in 2004.
Okay. Yeah. I mean, for example, to be completely honest with you, usually more or less all iliac occlusions can be recanalized. And actually, it's better to have that before having a fem bypass, where both groins you have surgery. And I personally like to try my best to recanalize the iliac arteries. Anyway, no matter what, but you have this kind of blockage. And now, do you have the possibility, did you see anyone to try to unblock your blocked iliac artery or not?
I was told that it's not possible to get through the left artery that's blocked. And the vascular surgeon that I saw was the one who mentioned doing that procedure that's similar to what Douglas had.
Yeah, I'm thinking that we need a different doctor. I just messaged you, and I think Lorenzo will agree. I think we need a different doctor to give you.
No, I definitely think that I really want, to be honest with you, I can't recall an iliac occlusion I couldn't cross and treat. And actually, usually these common iliac artery or iliac artery is treatment, they're usually quite good, because usually the vessels are quite big, and the stents tend to keep patent for longer compared to like the thigh. And I definitely think that you deserve someone who can open this artery. In the meantime, I would like you to also to understand if your problem on the side where the stent is patent is related to PAD. Because if you have, then maybe there's some other blockage down there. But if you feel, you said that you have rest pains, you have pain in the night on both sides, am I right?
Yes.
And did you do ABI?
I don't know.
Okay, because it would be nice to understand more if the pain on the right, on the right, I think, where the stent is patent, if that is correlated to vascular or not. What do you do in the night when you have this pain? And that's an important question.
Usually I would take some Tylenol to try to alleviate the pain, but mostly it keeps me awake most of the night.
Okay, do you do anything in particular? I'm talking physically.
Get up and walk around.
Okay, yeah, that's you see, that's the question that needs to be answered, because people who don't have arterial disease, it's very simple. When you stand up, the gravity helps you in getting more blood flow down to the toes. So whenever instead you are lying, this kind of gravity effect is not there. So that's where you develop the pain. So if the answer to my question for my patients is I put the leg outside from the bed, or I try to walk around, that's the right answer to for me to understand that it is a proper vascular problem. If you say, for example, no, I move in the bed, I massage, I try to change position, that's not really possibly vascular. So, but if you say that you wake up, you try to walk around, you try to put the leg outside in the bed, that's a sign of vascular disease. But I would like you to be investigated. So the thing is, for the left side, the one which is blocked, you need to find someone to unblock it, 100%. On the right side, you just need to be investigated a bit better in order to understand if your disease is properly vascular. This is what I suggest you, to find a doctor which does these two things. Check on one side and treat the other side.
Okay, thank you.
Yes, we'll help you with that, Carmela. Thank you for your courage and your strength and for being here today. I do have a question that's coming in from Nora, and then I'll get back to other questions in the live studio audience. So be prepared. I'll get to Marcia next and then Douglas. And then if others have questions, just let me know and raise your hand. But we do have a question from Nora that came in just a little bit earlier. I have a hard time taking the stairs with venous insufficiency. Would exercise help with CVI?
Okay, that's a good question. The only thing I want to understand if it's a deep venous insufficiency or instead the superficial venous insufficiency. It makes a big difference.
She
Is it
didn't
the
specify.
saphenous vein?
She didn't specify. So would you mind just giving us the
Okay.
difference?
Sure, yeah, definitely. So essentially, there are two different systems in the legs. I'm talking about veins. So there's the superficial system and the deep system. The superficial system is the one that really doesn't really doesn't have a big importance because it's the one which anyway drains into the deep one. So essentially, the veins can be burned, they can be cut, they can be removed, and actually you have no impairment of the venous circuit. So it's important to differentiate this, which can be treated surgically or with like avulsion of veins. So you remove the veins or you cut the veins, or with endovascular techniques, burning the vein from inside, compared to the deep venous insufficiency. Deep venous insufficiency, unfortunately, is the one that usually people have swollen legs. And I think that the case that you mentioned before, Kim, of our patient is a superficial venous disease. But anyway, the deep venous disease has no real cure because with a superficial one, together with also removing the veins and cutting the veins and blah, 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 you can also use compression stockings, which are pushing the superficial veins to squeeze the blood into the deep venous system. So the typical question of people who undergo any kind of superficial venous surgery or treatment and say, oh, doctor, you're closing my vein. Oh, doctor, you're removing my vein. Does it mean that the blood flow won't circulate anymore? No, because that's the deep system. But if the deep system is affected, then it's like a bit more tricky because the only thing you need to have postural therapy, but there's not really anything you can do for that. The thing is like what insufficiency means. Insufficiency means that, the veins, in order to bring blood flow from the toes to the heart, have valves. Because, the vein flow is going against gravity with low pressure because the heart pushes the blood flow into the arteries, but, the pressure in the vein is very low. So what the body developed, it's like you have valves, and these valves are one-way direction. So the blood flow is pumped up, goes up like in a lift, and then the valves close. And every time there's a pumping, the blood flow goes up like on a stair, and it doesn't come down. But if you have insufficiency, which means that the valves in the veins don't work anymore, that means that the blood, instead of going up and staying, goes a bit up and down because all these valves are floppy and they don't keep this kind of mechanism for the blood to come up. So that means that the blood will stay where it is. It will feel heavy on your legs, and it will possibly cause varices because all the veins are getting pressurized because there's no good outflow from the superficial venous system, and they get this kind of varices, which are not like life-threatening, but it can be annoying.
Thank you. That was the best explanation ever that I've heard on that. We have Marcia. Marcia, go ahead and unmute. Ask Dr. Patrone your question. Then we're going to get to Douglas and Hines and Kim.
Hello, doctor, and thank you for being here. Congratulations.
My pleasure.
I have 100% blocked SFA with stents that have reblocked, and bypass has been mentioned, although I walk a lot, so I have pretty good collaterals. But, every day I have pain when I'm walking. So bypass has been mentioned. My question is, I don't want to invite more trouble by getting a bypass and then have it fail. And so my question is are all bypasses destined to fail? And also, what about the new thing? And Kim, you might need to chime in, TFAO or T...
PTAP. So
PTAP.
And we do have a couple of doctors coming on later this month to talk about PTAP, but it's the detour system where you're hijacking a vein in the thigh.
So am I better off to leave it alone and just do my best to keep walking since I am right now?
How long can you walk without any pain?
Oh, I don't walk far, but I mean, today I did a hike. I did 4 miles, but I have pain. But
Okay,
you
but
know, but
you
I'm
know,
doing it.
okay, I understand. But how after how many meters, more or less, you need to stop because of the
Well,
pain?
let's just say after about 3 minutes, I want to stop. I don't know how many meters because you know we do
Okay,
miles here, but maybe like a
yeah,
tenth of a mile,
okay,
just a
okay.
few
Yeah,
minutes.
I mean, to be honest with you, it's a bit of a tricky question. I mean, like, of course, everything we do could be endo or open is something that the body usually doesn't like. I mean, like because it's something like external to your body. So the body is a machine which reacts to external things in a bad way. Generally speaking, it's like it's anything that we do, anything we fix is not forever. Of course, there are cases like, especially I would say, vein bypass, where I've seen patients with 20 years bypasses which are still running. If you have a vein bypass, so for
I
example,
don't
that's a
have
big, you
no
haven't.
viable vein. I
Okay,
had a
that's
study.
another thing. Okay, good. So that's good to know. So the vein bypass is usually very durable. The graft, like usually with the with the like a like with a graft is not that durable as the vein. Having said that, it's not like it does. There are like 1,000 different possible outcomes of a bypass. I mean, like could be that the bypass, even with a graft, will stay pain for years, and maybe they will give you years of pain relief. The thing is, like always thinking about you're young. Anyway, you're not like 85. You're not in critical limb ischemia. You can still live like a reasonable life.
Mhm.
So like there's always space for a bypass. I mean, especially because you don't have a vein. So essentially, it's something that can be done at any time. It depends a lot on how you feel with your life. If you feel it's very impaired, I'm sure you can discuss about doing a bypass. Or if you don't feel that constant handicap in having this kind of a short, let's say, distant claudication, then you can keep it as it is. It will never go worse, especially if you take aspirin and statin. I don't know if you take them.
Yeah, rosuvastatin and a baby aspirin.
That's perfect. Yeah, that's by keeping these two drugs and by always like having it looks like very healthy lifestyle, then you're fine. The thing is, like, to have a bypass is, of course, it's invasive. No one tells you that you won't have any complication like infection, graft occlusion, blah blah blah. You get a scar, and you have there's no one who can ever tell you, okay, whatever I do will last X amount of time. It could be forever. It could be like 2 months. Another great sign is like your stents went down. I don't know how the procedure was done. I don't know the size of your arteries and many other factors, but to have stents which go down already, it's not a great sign of long-term patency of whatever you do with you. I mean, there's also the option to open the stents again. It's not something that it's not done. But again, you need to see if the stents were positioned properly, if the outflow, down, below the standard zone was okay. There are like many different options that needs to be checked. Having said that, in order to summarize, is like it's good that you have an active life. I think that's the best. If the pain is not too bad, if it was my leg, I wouldn't get a bypass. When the pain becomes untolerable, of course, you don't smoke now, do you?
No, I quit.
Okay. That's important again. So as long as you keep your drugs, you don't smoke, I don't think nothing will go worse. The only thing can go better. So, but if you reach the point where you think really that your life is, you know, severely impaired by your disease, then yes, you can go for a bypass at any time because it's a bypass which involves a graft, and like more or less everyone can do it. It's not a difficult surgical operation.
We always, tell our patients that, right now innovation is moving at the speed of light for peripheral artery disease. And, we really, really suggest that if it isn't lifestyle limiting, if it's not impairing your life, if you can tolerate the pain, really try to push through it as much as you can, because, as you said, like you don't want, there are only so many procedures that you can have, before it becomes those become limb threatening. And I know going forward, there are some great technologies. There are some biodegradable, bioabsorbable stents that are in the works. And you have also Reflow Medical that has a retractable stent they're working on. So a lot of technologies are coming out that would ultimately not impair a doctor's ability to have a really good landing zone in the future for a bypass if it is ultimately necessary. And maybe they try a couple more interventions in the meantime, if those become medically necessary as well, if your symptoms do get to the point where they are lifestyle limiting, right?
Guess I'm looking for a magic pill.
Yes.
There
And
isn't
also,
one.
Christina, you were asking also about the D2 trial and the endologics, like when you, so essentially artery and veins are very close to each other. So when you go down into the leg, the artery and the vein are close to each other. And there's this kind of new sort of treatment that they propose, like it's from the artery, which is all occluded, standard, whatever, you cross into the vein.
Yeah.
You take a tour into the vein, you go down, which is pretty easy done by our guide wires, and then you re-enter into the artery. So you do it like a bypass, the same thing, and you actually put the graft, so exactly as the bypass, but going through the body into the vein. Okay, so arteries are the vessels which are bringing the flow down to the toes. Veins are the ones who are bringing the flow from the toes and then bringing it back to the heart. So there's this technology which is now still not like completely, of course, on the market freely, that you have a passage from the artery into the vein, which is something completely against nature, if you want to say.
Right.
And then you cross you go down into the vein, which is patent because it's not blocked. And then you come back into the artery. Okay. So you bypass the occluded artery passing through a vein. That of course can raise some questions. The main one is like, okay, what about the vein? Is it going to be blocked? And actually,
Right.
we're talking about, again, the deep system, the system which is very important for you because it's the main one of your body. Actually, they demonstrated that there's not much. Of course, you need to have some criteria. You need to have the vein which is as big as, or like two veins, or there's some criteria which need to be fulfilled. But essentially, what happens, like more or less from the patency point of view, I've seen more or less the same patency rate of a graft. So it's more or less the same. So it's not super great. And personally speaking, also you need to have a little stamp, especially on the top, because they're putting cover stents, and the cover stents don't let the blood passing out. So if you put the stent too high, then you cover the profonda femoral artery, which is like an artery which provides flow to your thigh. And actually, that could be a little bit of a pain, dramatic situation. So essentially, you need to have certain anatomical conditions in order to fulfill the criteria, and then the results are good. The initial results are good, but I would say it's very much comparable with the standard bypass.
Okay.
Gotcha.
Thank you.
Thank you. Douglas, go ahead and unmute and ask your question of Dr. Patrone.
What an amazing spirit you are. We want to thank you for being here with us. I'm going to try and put two in one. I'm going to talk about bypasses and walking. I have an axial bifemoral bypass. It's blocked, but I've had one doctor go in and go around, but I feel it every day in my groin. So my question about that is that landing area where that's attached. Can that actually be causing the issue, or is it something else? Because I woke up today and I got a 4x4 sitting on my groin, and it's there all the time, especially when I drive, mostly when I drive or I walk. So the part about that is when we're building collaterals, does it make a difference if we're uphill, downhill, concrete, sand, dirt? So in our walking techniques, we're all trying to learn to walk properly. So when we're building those collaterals, is there a better way of walking properly to help accent that process of building those collaterals? And then for me personally, it was like the axial bifemoral bypass. It's like a 4x4 sitting on my groin 24 hours a day. So have you ever heard of an issue with that part where that graft comes in like that? Does that make sense?
Right. So you have two different questions there. One about the
Yeah.
different terrain for walking, and the other one is in terms of the axillary bifemoral bypass, where that it actually reattaches into the vessel. The whole thing is completely blocked. They've bypassed the bypass in the native vessels, but this graft continues because it's what, 6 inches, I think the doctor said, 6 inches from where it should have been. And so he's wondering if you've ever heard of such a thing and if it's possible that that might be causing those symptoms.
Okay, so let's start from the bypass because it's, let's say, the most difficult thing. So the axillobifemoral bypass is a bypass which is, let's say, technically very easy to do because it runs very superficial on your body. I'm sure you can feel your tube on your chest, you can feel your tube on your abdomen because it's tunneled very very superficially. So this is a bypass which is reserved usually to people who have no other choice. So essentially, to be honest with you, in my practice, we reserve this bypass for only people who are sort of about to die or they have a very severe disease because, I mean, they can't tolerate a long procedure, they can't go under general anesthesia, I mean, it's a very, there's a cohort of patients which are very much in this situation, but it's rare because, most of the people can go for any kind of sort of standard surgical endo treatment. So having said that, to have an axillobifemoral, it's not always a good thing because even in the groin, it goes very superficial. So that's why you feel the bypass very much like a 4x4, as you said, because it's superficial. So for example, every time you do a vein bypass in the leg, this is down the thigh. So you will never, ever feel the bypass, like you do with your own one, which is made of a tube, a graft, usually is reinforced with rings because in order not to kink. And so essentially this could be very unpleasant for a patient. So any kind of symptom, related to this tube and the pain and the suffering, it could be related to that surgery that you underwent. Then I don't understand where it should have been landed differently. I have no idea, but it's like whatever is done is done. And actually, when you talk
that part about that is where it leaves my chest, it goes like this. It's not one straight line all the way down and then crosses right under my belly into both legs. It goes, I can feel it. It goes all over the place.
Of course. I mean, you have to think anyway, when it was done, it's a long tube, which needs to conform with your own anatomy. Essentially, if you do it too short, then it gets pulled. If you do it too long, then it gets kinked. So especially when you do such a long bypass and you think about how much you move your arms, your legs, it needs to be a cut to size where actually the patient is in between. So you feel a bit like long when you close like an egg, or if you feel a bit stretched when you stretch your arms. It needs to be in between because the graft needs to move because this is how it works. And actually, it's a long tube made of plastic in a way. So it needs to adapt to you. When you talk about like a difference in a different way to develop collaterals, actually everything is the same. So it doesn't matter if you swim, if you run, if you ride a bicycle, whatever exercise you do with your legs, that means that the leg requires more blood, and because you require more blood, the body itself tries to respond by providing this blood. And if the vessel is occluded, you try to build these kind of collaterals which allow you to get as much blood as possible. Of course, after 3 years, you do intense physical activity, or even 1 year, I don't know, but let's say at least 1 year of doing good physical activity, you can't expect things to go better and better and better. I mean, you sort of maximize the flow that these small vessels can give you to your distal part of the occluded vessel. And then at that stage, you need to say, okay, I've done this best medical therapy, which is called like stopping, of course, the not healthy lifestyle, plus starting this physical activity, which brings you blood flow to the calves mainly. And if in a year that didn't work, that means that you had no improvement or little improvement that doesn't satisfy you with your quality of life, then you can think and you can consider something more. But again, you need to be a balance between the risk and benefits of whatever you do. And that's more or less it.
Did it answer your question, Douglas? Yep. Okay. I'd like to go on to, we have Heinz, then Alan, and we have Kim. Heinz, go ahead and unmute and ask Dr. Patrone your question.
I have to come back to you. I'm getting a call. Sorry about that.
Okay, that's okay. Alan, go ahead. Go ahead and unmute and ask Dr. Patrone your question.
Hi, Doctor. First, thank you very much for being here and sharing your expertise with us. We really appreciate it. I was diagnosed with PAD in mid-February, and from mid-February until the end of June, I was improving my condition by walking a lot. At the end of June, I came down with anemia, and for the month of July, I couldn't walk at all. And now I'm at a point where I've overcome my anemia. I'm getting blood work tomorrow that'll confirm that, but I know it's gone. But my PAD condition seems to have deteriorated since the end of June. I can't walk as far as I used to. I'm experiencing more claudication than I used to. I used to be able to walk 6,000 steps, and in the last 3,000 steps, I would be able to walk quite further without experiencing claudication. Now I can only walk 4,000 steps, and I experience claudication all the way through it. So it feels like I've deteriorated. I've made the decision that I'm not going to talk to my vascular surgeon, because the last time I saw him, he told me that if I can't improve myself, the only alternative for me is surgery. So I don't want to go and see him, because that means we're going to be talking about surgery. I'd just like to know what you think of my decision. Do you think I've made a good decision just to keep trying to improve myself by walking, or do you think I should go and have a chat with him?
No, I mean, like, it's essentially, first of all, no one is doing something against your will. So even if you go there, you have a chat that says that he will never ever told you need to have a bypass. Okay, so never, or any kind of endovascular, because it's not like life threatening. It's not. So it can offer you something, but you're absolutely free to say, no, doctor, I want to think about it more. Like, that's something very acceptable. No one gets pissed if you take more time to take your decision. Also, if this is like something that of course it's not really affecting you, as I said before, like the rest pain or ulcers and blah blah blah. I think that the best for you is still there are 4,000 steps, like still a good amount of walking. So like people who walk in my office and I say, doctor, I can only walk. Even when I came here, just from the lift to your room, I had to stop because of the pain. That's one sort of claudication which is really affecting them in everyday life. So yeah, these people I try to convince in a way to have some treatment, because it really could be really life-changing. For you, I mean, of course, you need to balance risk and benefits, and I think that it's up to you. If you really feel that this is affecting your life in a way that has never done before, and then you are limited in what you can do or you cannot do because of this, then I suggest you have maybe some procedure done. What I suggest you at the moment is just to try to understand how bad the situation is from the number point of view. So get an AVI and try to get at least the duplex scan in order to understand how big the blockage is, because sometimes the blockage could be 4 centimeters, sometimes the blockage could be 40 centimeters. And actually this puts also you in a different situation, because a blockage, which could be a stenosis, so a narrowing of the artery, which measures 4 centimeters, is a piece of cake to be treated. But if you have a blockage which goes, let's say, from the aorta down into the popliteal artery at the level of the knee joint, that's a completely different scenario. So try to understand better, try to talk to a surgeon or a vascular specialist you believe in, and try to consider all different options. Of course, balancing risk and benefits based on the amount of disease that you have. It doesn't matter if it's occluded or not occluded, but the length sometimes makes a difference, and the severity of your symptoms. Yeah. Don't smoke. get your diet balanced, and physical activity is already a treatment. So, try to go with it, and then you can go for surgery if you need, or if you think that this is really affecting your life and quality of life.
Yeah, and Alan, we always suggest, no matter what, even if the doctor does talk surgery, and we use it sometimes, as a general term, he might be, talking about doing bypasses or endarterectomies, or they might be talking about doing something minimally invasive. And so it's good to clarify. But in either case, we always, always, always say conservative therapy, number one, is best, and number two, to always get a second opinion before having any procedure, no matter what procedure it is. Always get a second opinion if you can.
Yeah, get a scan. The scan can be watched by different people. You can even send a scan to 10 different people. 10 different people can tell you 10 different answers. And actually, you try to pick the one that you think it's more reasonable, But I think, like, try to get a diagnosis made by numbers in order to, let's say, put a number to the severity of your disease, and also get a scan in order to understand how big the blockage or the narrowing or the disease is, because that makes a difference in decision making and treatment options.
Okay. I don't know what your timing is, Dr. Lorenzo. I know we're coming up on the hour, and we have quite a few other questions coming in. And I do have 3 at the very end that are very important that I'm asking every doctor now. So keep us abreast as to your timing so we can get through things quickly. We do have Heinz, though, who's here, who doesn't. He got that person off the line so he could ask you his question, Dr.
Yeah,
Patrone.
the coincidence with all that is there was a podiatrist I'm trying to set up an appointment with. Anyway,
Good, we suggest that for everybody. Get your appointment with a podiatrist regularly.
Right. So with that, Doctor, thanks for joining. A curiosity question. A few years ago, when COVID hit, of course, COVID was bad, no doubt about it. Then they came out with the shots for COVID. And the National Institute of Health published something that the CDC and the VG database said that you could have adverse cardiovascular problems from the COVID shot. So I kind of believe that I got re-padded or re-occluded because of the shot, but that's hard to prove. My question is, have you ever heard of shots, be it shingles or stuff like that have caused inflammations to the point of vascular disease?
That's a very difficult question to answer. So essentially, it's very difficult to prove any kind of the stuff. It could be the COVID vaccination, which damage they do to endothelium. That of course, what happened during the COVID pandemic, it's like to understand what the COVID disease means to our body. So essentially, at the beginning, we thought was something, then we thought about something else. So essentially, it has demonstrated that the COVID itself, the virus, promoted some sort of thrombosis of vessels. So essentially, many of the complications of COVID was caused by this kind of microthrombosis. So I don't know what about legs, but for the heart, because these people died. So it went in a way. I know it's sad to say, but if someone dies, you can investigate better because you can remove the tissue from the organs from the body. You can check them. You can see what's going on. Because no one has ever investigated an artery outside from the heart. Because what's the point in no one ever died of leg disease, and actually no one ever cared about checking the arteries after possible COVID infection. So it's difficult to say. It's impossible. No one will ever tell you, oh yeah, that's because of the COVID disease, that's because of the COVID shot. It's very ambitious to say that. The thing is, I think that any infection, especially the COVID one that's demonstrated to cause thrombosis, can have caused this kind of maybe even worsening of your situation. What I think now, whatever you have, doesn't matter, what the cause was, and no one really cares from the treatment point of view, which was the cause of your blockage. So if you think that, as I said before, that whatever affects you, the PAD which affects you, really change your lifestyle, then you need to seek advice and potentially treatment. And it doesn't matter if your cause was made by, I don't know, smoking, diabetes, COVID. If you have a blockage, you have a blockage, full stop. Of course, some blockages are more like calcified. The pathology can be more severe, but at the end of the day, it's always a blockage. And it's affecting you the same way. If you have a soft blockage, the same thing as having like a rock solid blockage. Then, of course, the treatment can be different. It can be more challenging or less challenging, but at the same time, you have a blockage which affects your life. So,
mine's from radiation therapy, by the way. Mine's not from
radiation therapy. It's a bit of an annoying thing because the radiation makes the tissues it makes a scar. So essentially, every time there's a radiation therapy, then it's difficult to treat because the vessel is cooked, sort of. Yeah. So, but as again, you need to understand which your symptoms are, how you can get a referral to someone who understands your disease. And after that, you need to understand if there's any point in treating you. And, it doesn't matter then at the end of the day, what was the cause of that. Of course, as I said, the radiotherapy can add difficulty to your treatment because the vessels are really cooked and full of scar. But apart from that, the cause of the worsening of something doesn't really matter at the end of the day.
So basically, the vaccines that people get, and I want to get possibly the Shingrix or the shingles vaccine, I shouldn't worry about it, basically.
No, I don't think you should worry about your legs with the COVID vaccine. I don't think so. But now I think the COVID vaccine, I mean, if you're not really in a condition where you have important comorbidities, like immunosufficiency or other disease which are like well known, asthma, severe asthma, this kind of stuff, then I don't think that at the moment a COVID vaccine will help you with anything. COVID has become slowly like a normal flu, and actually I don't feel like the need now for a semi-healthy person to get a COVID vaccine. I don't know what's going on in the US, but in Europe, no one does it anymore.
Yeah, and in here, it's not necessarily required, but we do have to say, because YouTube will cancel our video if we don't have the disclaimer to say, make sure you do follow the World Health Organization's recommendations. You can go to the World Health Organization's website and see what their views are and what their recommendations are.
Thank you, doctor. Sure. Thank you so much.
So thank you. Anything related to that, we always have to say, or else they take down our videos. So we just have to actually put that disclaimer out there. Censorship at its best. So we just have, do you mind 4 more questions from them and 3 more from me?
It's absolutely fine. The only thing I need to put the phone on charge, but you can go ahead. I just need to walk somewhere else so I can take my charge.
Okay, we appreciate your time so much. We have quite an audience that's here, both in live studio as well as watching online through YouTube and our groups. So you're very popular, of course. It goes to show everyone's so appreciative of you and the time that you spend in our groups and supporting everyone. So I want to get to Kim's question. Kim, I don't know if you want to unmute and ask your question yourself.
Yeah, hello.
Hi, Kim.
Yeah, hello. I was just wondering, I know doctors want us to lower cholesterol as low as possible, but is there a time that it becomes too low?
No, that's really not. I mean, like it's impossible to get it too low. Essentially, it's good that you try to lower the cholesterol, which is high. But when it goes into a certain range, then the body reacts itself, because the cholesterol also is important for, I mean, it's not like only bad. It's important to have the right amount, so it doesn't go too low, because it's impossible to send it too low. It's because the body reacts by burning more stuff, so it's very difficult to go too low. It's not like sugar with diabetes. Like you can go, for example, if you take insulin, it could be that it goes too low, because then it could be a dramatic position you're in, because it could be like you can go even to coma with too low sugar in your blood. But that doesn't happen with cholesterol. So be sure that all the drugs that you take, of course, are let's say balanced on your cholesterol level, but no worries about having the cholesterol too low.
Okay, I just wanted to ask another question regarding that. Like in Canada,
Sure.
the levels for LDL cholesterol are acceptable range for them are 1.50 to 2.65. But at my latest one, it said 0.68, and they flagged it because it was so low. So you're saying that I don't need to worry, even though it's way below the guidelines?
Yeah. I mean, like it's not a big drama. I mean, we talk about LDL or HDL.
LDL.
And what about the HDL?
My HDL is a little bit low.
Okay, it's fine. It doesn't really matter. No, I mean, actually, you're in a good situation. I don't think there's any issue with that. Did someone tell you that there's an issue with that?
No, I haven't seen the doctor yet. I don't have another appointment for a couple of weeks, right? But I was just wondering, since it was so low, could I back off on my cholesterol med a little bit, or should I
Of
just leave
course.
it?
Sorry. Yeah, I didn't know you were on a cholesterol man. Yes, of course. I mean, it's like the less, I mean, usually speaking, the less drugs you take, the better it is. So essentially, if you can get out from the cholesterol pill, then it would be good. Do you have PAD?
Yes.
Okay, because that's the other thing. Like usually, because I mean, it's a bit complex to explain. But the pill for the cholesterol doesn't only lower your cholesterol. Okay, also makes the plaques that you have, especially in your heart, more stable. It means like it creates a plaque which is more solid. It doesn't increase or decrease the size. It just changes the way the plaque is formed. So if you have a more stable plaque, that means less chances of this plaque to go around and potentially cause more damage. There's less chances of this plaque get ulcerated and to create thrombus and eventually blockage. So with PAD patients, we always have also some even minor or like, of course, silent cardiac disease. It's also important to get the cholesterol med, not only just to lower the cholesterol, also to make the plaques more stable. So I would say talk to your doctor, and essentially you can, the best is not to talk even to a vascular doctor, to talk to, let's say, a general medical doctor, like the ones who are managing the drugs, and like a general medicine doctor, and ask what they think. And you can also try to lower your, for example, I don't know, you take, I would say atorvastatin 80 milligrams, you can go to atorvastatin 40 milligrams and check how it goes. The same with the pills for the blood pressure. You get the pill, you try to adjust, and you see how it goes. So this is there's no rush in doing that. There's no danger having the cholesterol too low. So take your time, but it's a conversation you can have with your doctor. Yes.
Good
Thank
question.
you very much for your answers.
Thank you, Kim.
Pleasure.
I'd like to open it up to Don. Don, go ahead and unmute and ask Dr. Patrone your question. Or I think you have two questions, but ask one at a time.
Hello, lovely to see
Hello.
you. We spoke on the phone actually.
Oh.
I just have a couple of questions. So one, I'm in part of a research program in a hospital in Utrecht in the Netherlands, and they came back. I had scans and everything, blood taken, all this, and basically they came back and they said they've got no idea why this has happened to me, actually. And then they were talking about, so none of the normal reasons are there. Everything else is great apart from one leg, which is completely blocked. And then they were talking about maybe it's blood clot from somewhere. We don't know if it's there now, if it was there, if it was, where did it come from? And they were also talking about inflammation in the blood, or indications in the blood that something is inflamed, but I don't have anything that's, any wounds or anything like that. So I suppose my question to you is, what do you think? What do you think about these hypotheses? That's what they said. They said they are hypotheses because they don't actually know.
I know probably this doesn't sound very reassuring to you, but there's a bunch of things that we still don't know. And, think about, there are two things that people really struggle with. One is the headache, and the other one is the high blood pressure. And, there's no real cause found for the headache, which affects millions of people in the world. And the same thing with the primary blood pressure. So the ones that you don't know where it's coming from. It's not like a stenosis of the renal artery or whatever. And between these things that in medicine we don't know, there's also some disease that we can't explain. Sometimes people come, they're young, they never smoked, they are also even like completely negative for vasculitis screen, and still they have blockages, still they have the disease. Of course, it's a small amount of patients. I'm not so glad that you're in this group, but the thing is, I think that the inflammation, as you said before, for a CRP or some sort of a marker which is high, which is usually these markers are very ambiguous. They could be anything. They are not really giving us any answer. So the inflammation could be one thing. Because did you smoke in your life?
No, never.
Do you have diabetes?
No.
No, you see,
I have low blood pressure. I don't, yeah.
You're an healthy person. So essentially,
I am.
they don't know really what to do.
Yeah.
And then potentially, you know what happens, like the moment you do an intervention, it goes down straight away. It could go down very, very quickly. So my suggestion is to try, of course, to be, I mean, Netherlands usually are a good place. And actually, I think that's, they investigated you quite a lot, and that could be good. So you of course, you check for lupus systemicus, you check for antiphospholipid syndrome, you check for vasculitis. I'm sure you went through all the screen. And I don't know if you are on any kind of steroids. They give you steroids.
Okay. Well, I have statin and blood thinners.
That's it. You don't get steroids, do you?
No.
And this is the only disease which affects you. You don't have any other disease in any other part of the body, am I right?
No, well, I have asthma, but that's
Okay.
But yeah, nothing
But you
else.
don't have
No, it's very odd,
did they check your carotids, for example?
Yes, they checked all this and everything was great, apparently. Yeah, which is
Okay,
great. Of
so
course, it's good to hear it's great, isn't it? But then you come away later on, you think, well, what then?
yeah, I know. I understand that. The
it's
more you get
interesting.
negative tests, the more you ask yourself, okay, what's wrong with me? I understand.
Yeah.
It could also be that you had a clot, which was, at some stage you got some atrial fibrillation or some heart problem. This clot moved down to your leg. It blocked the leg, which is otherwise is completely healthy, and this could have been the cause of your symptoms. And of course, that it could be which kind of symptoms do you have now? Do you walk? Do you struggle to walk?
I walk and it's painful to walk. Yeah, I walk.
How long? How
I'm
long
quite
do you walk
tough.
for?
Well, I can walk. The pain starts after a few minutes, but I keep going and I can go really quite a long way. Now I do today I did about an hour actually.
Okay.
But
So to be honest with you,
it's not
never
very
let
fast and it's quite sore. But I do
never let anyone touching you in this way, because it's
Okay.
you are keeping great balance, and I don't know what your disease is because no one knows. If you do anything, then it can go even worse. So I would say until you really struggle, then don't let anyone touching you, despite they try to try new things or stuff. So keep conservative. You can walk, let's say, I know it's a disease, and I don't want to say that it's not important to you, but believe me, in the range of, let's say, from 0 to 100, you are in the lower 20s, okay, of the
Yes,
disease
I mean
itself.
yes, I know, and it's true. Of course it is, but at the same time, I'm not very old, so my life is quite restricted in that way. I mean, my kids want us to go skiing. That was my second question. And I haven't been able to go since this happened because it's just too cold. My foot gets really, really cold. So I just want to ask you also then, is it actually dangerous to be in a very cold situation when your foot is
Not
very
at all.
cold?
Not at all.
No.
No, not at all. The
No.
only thing that can be dangerous when you have very distal disease. So when you have like very disease, which is not your case, usually old people with diabetes, then that could be a bit more dangerous. Not at all. It's just the thing that, as you said, the feeling of being cold is not pleasant.
Very
But
cold. Yeah.
from the body point of view, there's nothing really can go wrong. I mean, of course, if you put your leg into the ice or in the snow for 2 days, then of course you get frostbites like I would get. But apart from that, it's just the pain that this cold is causing you, but no potential damage at all. Zero.
Now,
All right,
Don, I
that's
just
my
want to
goal.
speak. So, when you're walking, one of the things that you really want to be conscious of is you got to try to push to a brisk pace to try and get that onset of claudication sooner rather than later, and try and push through at that same brisk pace until it gets to a point where you want to cry, and then you got to stop. and then you rest, let the claudication dissipate, and then do it again, and set aside 30 minutes a day to really treat your walking regimen as if you're in the gym and you're doing those bicep curls and your trainer is saying, just give me one more, just one more rep, just one more step, and see if that helps to improve what we call your claudication time. And that's the time between the onset of your pain and the point at which that pain gets so bad that it makes you want to slow down. Instead, you need to stop. And so we see this with a lot of patients where they say, well, I'm walking at a pace that I'm not really, going, I can't walk very fast. Well, the point is you got to walk at a brisk pace. It's not how far or how long you walk. You got to walk to the point where you are in pain and walk through that pain, because that's when you're going to trigger those collateral vessels to grow. And
Yeah, but at the same time, it's good. It's good what you do. You slow down the pace and you go at a lower pace, and then you keep walking. So essentially, also this one is like getting to the limit and pump it to that point is very good. So you don't have to walk as fast as possible to get this pain. The more you manage and you balance, your symptoms with your walking capacity. That's a great thing. That's a great thing that you learn. Of course, you're very active, very young, so it works well. But keep doing that.
Yeah, here in the
Okay,
US,
so it's a
they
bit of a
have,
mixture. So thing is, Kim, if I go fast, then I don't even get to the end of my street and it's already very painful.
Yeah, sure,
You
but it's the
know?
same thing with
So
the
but if I go
uphill and
just
downhill.
Yeah.
indeed, yeah, and I have done quite a lot. And I walk now with my husband, and I kind of lost sense of like how fast is it? Is it normal pace? Or am I going too? I have sort of asked, like, is this normal?
Yeah, you don't
Is this
need
a
to
normal
speed
pace?
walk, but you
And
need to go
they were like,
you
they
just
were
need to
going,
go at
well,
a
actually,
brisk
that's
pace.
okay. Like, when you think, okay, that's all right then. And but yeah,
Yeah.
I feel it all the time. It's never not there. When I'm
Yeah.
walking, it's always there. And it's a bit of kind of one of those things, like when you're at work or something, I have to go to a lot of companies, different companies, and of course you get there and my heart sinks when they go, yeah, the meeting room is on the third floor at the back of the building. And I'm just like, oh no. And I know that they're gonna walk too fast for me, and I'm there trying to look like it doesn't hurt. Do you know?
Yeah, we had Dr. Anita Dua come on because she just written some papers on it and such, and so she explained just last week her method of doing it, and she wants to see that claudication sooner rather than later here. But it depends on the person, right?
I
What
think
you
I
can
hear you both,
tolerate.
and I'm doing a mixture. So I am. So I go to the gym, and then I feel like more comfortable
Good for
there,
you.
getting into pain in the gym somehow because it's more private, not
But
out on the public streets sweating away
right.
like,
So
why is this hurting so much?
the other thing, and I don't know, Lorenzo, here in the US, we have a cardiologist that, talks about, when he can't figure out why someone doesn't have, or why someone has PAD and they may not know why. And Dr. Patrone mentioned, one of them, which was AFib, because you could throw clots. 2, he looks at valvular issues in the heart. Number 3, he looks at the aorta top to bottom to make sure there's no aneurysms. And then number 4, which was interesting, is and it's even on the American Heart Association's website. He says he sees a lot of damage to the arteries because of what's called an MTHFR mutation, which makes it tough for some people's bodies to turn food into fuel. And so something happens in that system, but the important part is there's one enzyme called homocysteine that is not broken down for these people. And so he explains it as being like nails on an artery wall when there's too much homocysteine in there. So he actually treats patients and tells them to take a liposomal B12, and I think it's methylated to help with that. So just some interesting things that might be.
Yeah, of course, everything which she said is like needs to be proven by some sort of trials. So essentially, I can come up
Exactly.
one day and say that if you don't drink 2 coffees a day, then you don't get the right sprint to walk farther. But I need to prove it. So essentially, yeah, it's good that people are, of course, trying to understand the body a bit better. But everything needs to be proven.
Yep, exactly. Everyone just has these theories, but we just don't have the evidence on a lot of it. So, but it's always worth exploring. And we have, let me just say 2 quick questions from, if we can make them quick. We have Marie, do you have a quick question you wanted to throw in there?
Sorry, if my battery goes down, just wait for me 2 seconds. I will try to get in again from my computer, but just in
Thank
case.
you. We
But
haven't
wait
had
for me.
so many people coming on in this. Everyone just loves you. Of course, they love you. Okay, so Marie actually says barely able to walk 25 feet right now. Leg is not turning dark like it had in the past. I feel everyone around me is trying to pressure me into surgery, and I'm just not mentally there yet. Do you think I'm okay to keep trying to walk? Also, my foot does turn purple and then will turn an almost dead gray, but then it goes back to normal coloring again. And it seems to be a theme: surgery or no surgery.
No, I mean it's all about you. I mean, it's not. No one can really convince you. Of course, if you were a very active woman before, now you're not anymore. You don't go out, especially in the winter. Then of course affects all your quality of life and also your life generally speaking. Because the more you stay at home, the less the lungs open, and there are loads of stuff. So essentially, it depends how quickly this deteriorated. I would say 25 meters is a very short distance claudication. So it would be something that I personally would support a treatment of. Having said that, it depends on, of course, how much you were active before, how much this impacts your total quality of life, and at the end of the day, the decision is yours. But again, 25 meters will suddenly, at some stage, I would say not very late, turn into rest pain. So, because it's very short distance claudication means that you will start having pain at night and blah, blah, blah. And going into the CLI spectrum.
Yeah.
It's up to you, but yeah, I would suggest you to have surgery too, some sort of surgery, some treatment. And but it's completely up to you. It's not life-threatening. What you have is not life-threatening. If you're happy with that, keep it. But if that severely impacts your quality of life, then of course it's a sort of a downhill trajectory. So try to get treated and to start living again. Don't be afraid to go back to your normal life.
Thank you. And one more quick question from Nancy on LP little a. This is something that's so interesting just because we're seeing, I don't know if it's just my social media because Facebook has targeted me and being someone who talks about vascular a lot, but I'm seeing over and over and over all of these ads for all of this research around LP little a. And I think that, Nancy, that is something that you're going to be asking about the research.
Yeah. I just volunteered for Eli Lilly's the clinical trial for a new drug that they're doing. I've always struggled with high LDL. I am diabetic 25 years. I've had a heart attack. I had a widowmaker. I have a defibrillator. And now I have had pads since 2019. And I'm fighting hard. I'm 71 years old. So do you know anything about this lipoprotein A? And if you've heard of anything that can fight it? Because what I'm understanding, there are no drugs for it. And I do take Pata because I'm allergic to statins.
Okay, so no, to be honest with you, it's not something I'm familiar to. I have to confess. So it's better you ask someone like who deals better with drugs. Of course, it's a bit of I don't know how much this trial has then led to a change in guidelines. So it's important that, every time they do the guidelines, they do every 3 or 4 years. Of course, I don't know, we're going to write now. I got the invitation a few days ago to write the global guidelines, the new global guidelines between European Society of Vascular Surgery, a Society of Vascular Surgery in the US. And actually what you're going to do when you write guidelines, you look at the evidence which came out in the last years compared to the last time the guidelines were made. And actually after that, you try to come to some conclusions. Okay, were these trials really impactful or were not really meaningful for the disease? So I'm not aware of this trial. I mean, you can share it with me if you want to. You can share it online. You can comment on that. I can read it. But, until the things are not well established into the guidelines, I think that you are still in the point where it's not experimental, but not established, at least not established therapy.
Yeah.
We probably won't see something for in the guidelines for maybe 6 years or more because, it takes I know it took, we just released the 2024 US guidelines for PAD, and Dr. Mehdi Shishibor had said that it took them 3 years to write. And he said he already is now seeing new evidence that he wished they could have incorporated into it, but now they're starting to write the next set of guidelines. So you said in 3 years, the evidence today is going to be reflected in the next set of guidelines in another few years.
And of course, as Dawn has written, there are loads of trials going on every day. All doctors have different ideas and they run trials. But you know, from the idea to the final result, which is very impactful, it's a long way. And actually, it's very frustrating sometimes writing trials, also to get, you know, not the results that you expect. It's a painful process, but you know, we all do that.
Yeah. What you can guarantee is that level 1 evidence, and that's really important, that you should know what the level 1 evidence is across, you know, the different guidelines, because that's what doctors, you know, will follow. And that's not something there yet for LP(a), but it's interesting to follow the research as it goes along.
Yeah, I just
Can
want
I just say, sorry, can I just say something on that? Because I was just told this just today from the man at the hospital, saying about this very same thing, because my level is also extremely high, Nancy, and my son's is as well. So I was really like, and so these trials, there's various companies that are doing at the moment.
Yeah.
And the man from the hospital was saying that it's quite the hot thing, as you've probably noticed as well, Kim.
Yeah.
And that they expect that there will be medication for this within 2 or 3 years.
Oh, wow.
this
Apparently, that's what the man said. So
the trial I'm in is 5 years, and it's my LDL right now is at 77, and I take Repatha, which is an injection every 2 weeks, and taking everything I can. I'm doing everything I can, and it's like now my grandchildren also have high cholesterol at age 13 and 16. It's like
oh my,
wow.
And, you know, they're athletic. There's no reason for this, and my sons have it, and it's like, okay, I'm just trying to figure this out because Kim always told me get an advanced lipid panel test. So it's similar to that. This is a little more detailed. And I was really surprised because my numbers are very high. I think I was at 237 and it's supposed to be at 77. So
yeah.
Wow.
Yeah. Yeah, mine was also off the chart. I don't know the number, but it was just also like, that doesn't look good.
This is what, you know, I mean, I hope they come up with a drug because there's nothing now. But I know they're also suggesting a lot of different vitamins and CoQ10 and just different vitamins to take. So resveratrol is another one, you know. So I'm going to do everything I can. I just keep looking for answers, you know.
And CoQ10 is something that's under the recommendations. I know here in the US, you can get a CoQ10 level test. I don't know about in Europe, but I know that you can here. And before you start just loading up with that, I would suggest just double checking your levels if you are here in the US, just to make sure how many you should be taking. And then also check with your doctor on that as well, because it also is dependent upon the level of the statin or Repatha.
Yeah.
Okay.
Keep you posted. I'm going to keep you and keep in touch with you. I'll be letting you know how this is going.
Would love that. I love when all of you, you know, everyone has different experiences and is involved in different research around the world. So it's always great, whether it's the physicians or even the patients that are participating, to always let us know what's going on, what's new, what's next, because I don't think there's any way, and I think Lorenzo also, but Lorenzo is more on the cutting edge, I think, than most doctors. Always has his hands in everything around the world. Anytime I need a doctor, I'm like, do you know a doctor in Australia, New Zealand, Japan? He's like, oh yeah, I know him. So he always knows what's going on. So it's good that everyone just brings them forward. So whatever research.
Yeah, but sometimes also the medical therapy is managed by doctors who are not surgeons. So they're more cardiologists and like more clinicians. So essentially, sometimes it's good also to match the two things, you know, the people who can pass a wire and the people who can prevent the disease going further. So there are different, even in the same specialty, the same vascular world, there are different people who are studying completely different things.
Yeah.
And everyone does his own bit and we try to put everything together.
Yeah. So I have 3 final questions here. These are a little bit loaded. They do need to be, you know, short because we use them for a few different series here, but the doctors are kind of enjoying these questions because they are loaded. So number 1, this is for our Journey to Diagnosis series. Share a case that had you scratching your head about how in the world did this patient not get diagnosed sooner, and what you wish would have happened differently with that patient. or you can share a story of a patient whom you just couldn't believe had other procedures and, you know, like spinal fusion or such done when they really should have been diagnosed and treated for PAD.
Okay, so that's a good question. The thing I really want to stress is like there's no real advantage in getting screened for PAD if you have no symptoms. No one will treat you if you are symptoms free. Then the another story is when you have some symptoms and people don't understand where your symptoms are coming from. So that is where essentially you need to have someone who tries to get together all the potential different causes of disease. What it could be called leg pain. Could be a nerve thing, could be like arthrosis, it could be vascular. But essentially, whoever presents with leg pain needs to be checked, at least with a very, let's say, simple physical examination and with the ABI test. So that's really just to exclude that you have a grade of PAD, which could be severe and which could be the cause of your symptoms. I mean, of course, I don't have a particular story, but I've met I met many different people who got diagnosed with back pain when actually they had a vascular disease, and for 1 year, maybe even more, they got labeled as a back pain patients, and actually instead they had vascular disease. Now that I think about a patient who came to me after 1 year of being diagnosed with gout. The gout is taking the first metatarsal joint, mainly, typically in the foot. And actually, this guy had this kind of ulcer at the level of, this level. He also had gout. But I think like no one, because of the gout, everyone underscored the potential of ischemia. Essentially came with this ulcer since 1 year, which was very annoying him because he was in pain. And actually, we found out that he had a severe vascular disease together with gout. So the moment we reopened his artery in the foot, he got the ulcer completely healed in 3 weeks. So this was a patient which was misdiagnosed, or to be said in a better way, he was underdiagnosed, because one of the diagnoses was right, he had gout, most he had ischemia. And because the two things were actually working together in giving him the disease, then one of them was overlooked. And the moment we treated him, he got better.
Awesome. Second question, share a case with a big lesson for you and others. Describe the patient, the frustration with the case, and the lesson you learned, and maybe others can learn from it. It could be a success, it could be a failure, either one. It could include a little bit of ingenuity on your part. But this one, just make sure you start it with, I'm Dr. Lorenzo Patrone, and an important case that I learned something is, or something like that. Oops, he froze. Oh no.
He said he might lose his battery.
He might lose his battery.
He said he would try and move and come back.
Yeah, it looks like he did drop off. So we'll let him have a chance to come back in a second, unless he thinks maybe that he's still on and he's actually answering my question right now and doesn't realize that he may be off. But it's really amazing that all of you are here. And so if anyone's here and then they're actually live, even online, we do have also one of his friends, Dr. John Rumback from here in the States, that is on in actually 1 hour from now as well. And he's going to be answering more questions. And so you can even come ask the same questions and get the different perspectives from both doctors. Today, we were just chock full. It is PAD Awareness Month. And so we are trying to just every single day provide an opportunity or multiple opportunities for everyone to be able to ask as many questions as they can. And Marcia, I think Dr. Rumback's is at 1:30 to 2:32 to 3:30, 4:30 Eastern time, 3:30 Central.
3:30 Central, yes.
And then Don, I don't know, an hour from now.
I'm back, sorry.
Oh, that's okay. Do you
Yeah,
want me to
because I
repeat
got it,
this?
as I said, my phone died, but I'm from the computer, but I don't have a camera. That's the only problem. That's why I was using my phone.
That is a-okay. We could always tape these at another time, but share a case with a big lesson for you and others? You know, describe the patient, the frustration with the case, and the lesson you learned and others can learn from it. It could be a success or a failure, it doesn't matter. It could even include some ingenuity on your part. But this one starts with, hi, I'm Dr. Lorenzo Patrone, and an important case in which, you know, that I had, which came with a powerful lesson, something like that.
Okay, so one of the cases that I remember the most, it was completely related to your activity, Kim, and it was the case of William Smith. I don't think he's gonna be annoyed by me mentioning his name. It was a guy who was actually in his 50s, and he got already an amputation on his left side, and he came to me with rest pain on the right side. This guy was quite active. He was, healthy. Otherwise, of course, very heavy smoker. And the doctor, 800 kilometers away from where I lived, wanted to amputate also the other leg. And the difference between being an amputee on one leg, on two legs, is huge. And this guy came to London without knowing me. Of course, he traveled a lot in order to get here. Oh, I mean, there now, because I'm in Florence. But anyway, to travel to London, actually, I put him on the table. And during a workshop, I did one of my technically most interesting cases. And actually, we managed to recanalize the whole thing. This was November 2019. So after 5 years, this man, after this kind of, let's say, a very complex intervention, has still his leg. He still walks on his leg. He doesn't have any more pain. And after 5 years, I can tell you that we saved the limb and we saved the life. And actually, I really want to thank Kim for that, because this was a very powerful human lesson. I remember William crying on the table because his leg became warm again. He said, I didn't feel that warm since years. And actually, this was very moving for me and for all the people who were present at the workshop. And, of course, there are a bunch of people on the other side that I couldn't treat, or we failed in treating, especially the ones who are the worst are the people who are young. Essentially, I remember one lady who had a very severe disease caused by acute limb ischemia. She didn't turn up to the hospital. I remember treating her and establishing a decent flow to a peroneal artery in the foot, and he was super happy. And she met my kids. She was super happy. And because the disease couldn't really be won completely, she was really dancing on the edge. Then at the end, she lost the leg. And by her losing the leg, it was like me losing mine also, because I felt really for her, and I could do nothing for her. And of course, there are like, for every let's say 20 stories or even more that you are able to 20 problems you can really be able to solve, there's one that you can't. And if you're sympathetic with the patient, you don't sleep at night thinking about that. And actually, it's very frustrating sometimes. The disease is too bad or too advanced that you can do nothing for it. And yeah, there could be many, but the case of this lady 2 years ago who came to me, and she was doing she was driving a car. She was doing a special driving art. She was drifting with her back. She was very talented, and she couldn't do any more without her leg. So that really impressed me. But we need to cope with these situations every day in our life. So yeah.
But I think it's important for everyone to hear, and especially the patients to hear, how you really do stick with the doctor. You really do. And there's so many that really do care. And I think that this, and Dr. Patrone's testimonial here really proves it, that they really do care. So thank you again, Dr. Patrone. And I have one more question for you.
Yes.
This is one of my favorites. Share 6 minutes that mattered in your career. It has to be a defining moment, a catalyst for change, a spark that led you into in a specific direction. It could be a conversation that you had with someone. It could be a scene in a show, in a movie, a documentary. It could have been a moment where you witnessed something that was eye-opening, but 6 minutes that mattered.
Okay, that 6 minutes that matters is for me is when I went to my first international congress as a speaker. I was invited in Germany, and I gave my talk. And actually, it was my first talk which I gave, so I was really hesitant in a way. I was feeling, of course, confident in what I was saying, but at the same time, I didn't know how people would have taken it. And when I sit down, I met a doctor which is called Michael Lichtenberg, who's a very big guy in the circus, and I didn't even know him. And this guy told me, "Oh, I love your cases, I love your passion. I would like to invite you to my congress in Germany." And then since then I met Dr. Mustafa, and then since then I traveled to US, and then I met Kim, and I think this 6 minutes of my presentation there, and the amount of let's say connection which I got with some very big names in the circuit just put me in the position where I am now, where I travel, I share my experience, I learn from each other, from other doctors. And I think this was very enriching for me, and potentially then for the patients which I daily see, or actually which I interact with online. So these 6 minutes really changed my life, and Michael Lichtenberg introduced me to, let's say, a group of people who are very passionate about what I do. And actually, if you ask me straight away, this is my question. And of course, there are many other 6 minutes in my life which changed, the way I am as a man. But if I have to mention one, this is.
Thank you. Thank you so much, Dr. Patrone, for all of your time. You've really gone above and beyond, and we appreciate you so much. For all who are watching, just remember the advice and views offered in this series are that of the speakers. Do not act on any information or advice provided here without the explicit consent from your own healthcare team who knows your situation best. But again, Dr. Patrone, we appreciate you so much, and for your commitment, especially for your commitment to patients.
Thanks a lot. I mean, thanks a lot for what you do for patients, and for all the people who fight every day for their own, of course, health issues. And, be strong, and be very much aware that all the doctors really care about you. Even the ones who look like they don't, at the end of the day, they do. Try to find one who really clicks with you. And then continues fighting, because this is a disease which can be managed in many ways. And if you have, the patience and the will of fighting, you have